So now you can see my screen and the slides. Hello?
Yes, sir. Your slides are visible.
Okay, so good afternoon. I just enjoyed the day today with you from all the lectures that have been discussed before from our colleague. I'm Ahmed Rabia from Riyadh. Um, the ECMO program director in King Saud Medical City, one of the largest hospital here in Riyadh, and with the oldest ECMO center also. Today we can discuss something that's like it's outdated regarding to the COVID. However, we use it to just help us in guidance of next generation for the COVID pandemics or any other pandemics, or at least if we have any other coming pandemics. So first, I have no disclosure, and I have a disclaimer that this consensus is not intended to replace any guidelines or randomized controlled trial or meta-analysis. It's a gather of an expert opinion with the Delphi exercise. We get all the controversial topic in COVID, and we gather it all together and to have some advices for upcoming pandemics. But further, we know all that the high quality evidence or consensus on managing COVID 19 patients requiring ECMO support is insufficient. Furthermore, there is a little consensus on allocating ECMO resources when it's scarce. This paucity of evidence and the need for guidance for controversial topics required an international expert consensus statement for a better understanding of the role of ECMO in COVID-19. So here we have 22 international ECMO experts worldwide who they collaborate and they do interpretation for the most recent finding of the evolved published research during the COVID-19, and they come out with an advices. This advices showed a strong consensus between the voter who is the 22 experts. So, and this is all the objectives as I told you. I will introduce the faculty. First is senior author was Dr. Robert Bartlett, and the scientific committee, including an expert for more than 5 years on ECMO, and the expert composition or a group of an expert worldwide, including Alan Baum, Dr. Mark, Matt Baden, Jailbreak, all are figures in the ECMO. Then we did an experience of some of the guest authors who are just formulating help in formulating the statement, but they did not vote for the statements. So first, I want to tell you that this project was started from the previous SWAC also, and it was in Riyadh. It took around 8 months with us over 5 phases until we finalize it. The first phase was included gathering of the 52 questions that may be debatable, and also the scientific committee do at that phase the expert composition and identify the gap of knowledge and the literature review. Then in phase 2, we gather the members to validate this question. Out of 52 questions, 13 were duplicated, and we validate 39 questions. The validation score was more than 75 percentage, and it all was web-based. Then in phase three, we have in this phase, we have a three face-to-face meeting. We gather most of the faculty during these three phases. At least every meeting was more than 50 percentage. At least they attached to the meeting actually. So first meeting was in Riyadh, and the second was also in Riyadh, and the third was in London. We come out with 15 statement. It was formulated by the members and also some of the guest authors. And out of the 32 validated question, we have three of the question actually we could not reach to a consensus. However, for the 15 statements, we start in the phase 4, the voting or the Delphi exercise, and it was done over rounds. The first round started, I think, 1 month back, 1 month after phase 3. And there is a rule for voting and the decision making. However, I'll just inform you now about the round. In each round, the faculty were asked to have their votes about the statement, each statement, in a scale from 1 to 10, and at the end, if we, according to the scale, we will check if it's a strong consensus or weak consensus, or the three that we don't have no consensus. Eventually, we have 13 strong consensus with 2 weak consensus, and after that, the last phase was to drafting and writing and reviewing for publication. The paper considered for publication now in Annals of Intensive Care under revision. Going through the some of the rules that we take in the methodology, actually the methodology running with and coordinated by King Saud Medical City, it's our center, and we included one methodologist, and we tried to be more clear and transparent in the methodology. Unlike other consensus, if you review other consensus, you can find that they coming out with the statement. However, if you want to check how the methodology, you can find it not well identified. So this was an important thing in our work here, just to keep it transparent. The exercise was conducted on a web base. We used the Google forms for each rounds, and the voting rule. I told you the voting was anonymous, 10-point scale from 1 to 3. This is a low, and from 4 to 7 is intermediate, and from 8 to 10 is a high level of agreement. Intermediate answer was meaning that I don't agree or disagree, and it was not I don't have an opinion. The coordinating center was doing a great job to make all the faculty understanding the process of the methodology. We allowed voters during each round If they think that the statement is weak and they give the statement low scale to give to modify or do rewordings, and we consider these rewordings for just a modification on the weak statement and going into second run. Successfully after over 4, we succeeded to shift to weak to strong consensus. The decision rule was the high score was above 80 percentage for sure. Our mean greater than 8. And the intermediate was 70 to 80, and low score below 70. So out of the 17 score, we have a strong consensus 12, and weak consensus 2, and no consensus was 3. So I will go through the statements in a hurry. Just because of the time of the lecture, and hopefully you will read it, inshallah, when it's published. We have 5 domains. Each domain have some statements. The first 2 domain are the bulky domain. The first include 5 statements. All are strong. One achieved strong from the first round, and second round, and the fourth from the first round. The first topic was a patient selection and intermittent mechanical ventilation. The score was 8.2, and the score rate was 19.4. The duration of invasive mechanical ventilation before considering ECMO should not be used as a primary determinant for ECMO candidacy. However, longer invasive mechanical ventilation duration with high setting may help decision making if concurrently considered with other factors indicating a worse outcome. We reviewed the literature in COVID, and as far as we have pre-COVID, we have some data regarding the association between the ventilatory days and ECMO outcome. We find in the COVID some of the data that coming out of some of the experience that no significant difference between higher and high number of ventilatory days or low number. However, we could not get the precise day of cutoff point. And we this was written with the rationale, and we asked for further prospective high quality research is needed, and using this invasive mechanical ventilation days with cautious, and it should not be alone and in context of the patient. The same was the score. The score statement was 7.9. The score rate was 76. There is no validation evidence-based scoring system to predict the outcome for COVID-19 patient receiving ECMO. Therefore, available scoring system previously used for non-COVID patient should not be used for a COVID-19 patient as a prognostication tool. We depend on this that we don't have any other scores in a COVID patient, and only one score from the previously score to the COVID was externally validated. Which is a risk score, showing the COVID-19 population demonstrated reasonable discrimination and slight better calibration. However, we think that it needs further adoption. Other than this, we don't have any other particular score to use in during the to work to use it solely in a patient selection. Then, the age in patient selection. The statement of age is strong consensus achieved from round 1, mean score 9.1, and score rate was 90.4. During a surge in patient volume, the cutoff age could vary worldwide depending on ECMO capacity and resource availability. As a result, we advise setting the cutoff age in a national or regional policy if required due to limited resources. I think no doubt that from the clinical practice that we find that there is a strong correlation between the age and patient outcome. However, ECMO was used in some countries for more than even 70 years. In our area, in the Middle East and let's say the emerging economic
Dr.
countries.
Dr. Ahmed Rabi, I'm very sorry to interrupt you in between, but we are running very short of time. So if you could just conclude in one slide or two.
Okay. So this is the age. This is the age regarding the age, and we concluded that every regional port can do put their policy and the cutoff of age. In the area, we recommend the area criteria to be used in a COVID patient. In the transplant, that was a weak consensus, and we think that it's feasible. However, it should be treated cautiously, especially in the event of that we have solid conclusion on that. The ECMO management prone, just Alan Comp, this is a post ECMO clinic, and we advise for this, and we have good experience here in SWAC also. And from position, Alan talk about it, but it has a strong consensus after round two. Regarding centralization, we have a good experience with new centralization here that it cover optimally the resource allocation, and we write our experience here in Saudi Arabia. Dr. Muhammad Azzam, he was the director of the new national ECMO program during the COVID, and I think it will be very helpful for all of you if you go through it. Then regarding the logistic, also new centers, it was a debatable in the COVID, and we have also our experience in SWAC here. For around 307 patients was gathered from India and the Middle East, and we compare new centers on all center, and we find that it's visible and no significant difference in a special situation. The transport also says that it's a safe for the healthcare worker, as it was the debate. And regarding the ethics fertility, we could not manage this fertility precisely. However, we stress on that the duration of ECMO run should not be considered for fertility, and eventually the prioritization, also prioritization, we cannot due to prioritize age or comorbidity or multi-organ failure. However, you have the predictors of mortality, and you can choose according to the context of the patient. Last three, no consensus, which is the cost of the service, and the precise prone definition for ECMO, and anticoagulation on ECMO. The value of this consensus, it summarized the experience, and importantly, it helped the future pandemics to be ready and guide future pandemics. It will be. So right now, I finished my lecture, and ready for your questions.
Thank you, Dr. Ahmed Rabi, for sharing your experiences. And due to the paucity of time, we won't be taking up any questions, and we close this session now. And thank you to the organizers for having us here. Thank you.